ICU patients, what's the best way to measure temperature? And then I might say, in ICU patients who are being cooled post-cardiac arrest, because that may be different than in other ICU, or in neonates, all right, or in an adult med surg floor, or in patients with mucositis. What's the best way to measure their temperature? Because we want to know when their fever spikes, all right? What's the intervention? So the intervention would be temporal artery thermometry versus oral thermometry versus axillary, and then C is the control group. And in some cases, C is usual care. This intervention compared to usual care, or it may be oral versus temporal artery versus pulmonary artery catheter. And we're using more. And then the outcome. And the outcome would be, what is that thing you're trying to detect? Fever. And the ability to detect fever. The ability to clearly delineate hypothermia. Right, so PICO, patient or problem, intervention, control. And again, control could be usual care, because obviously if you're looking at PICO, you're probably saying, I'm thinking about changing practice. And then what's the outcome as well? And if you look in medical literature, it's always death. But hopefully we have something that's a slightly more refined than that. Or complications, pressure ulcers. All right, so let me show you how we did this. Oh, this is from our librarians over there. So this is just another little chart. You guys have that in your handout. Who's the patient? What's their problem? So you could either say in older adults or in older adults with heart failure. In younger adults with heart failure, that's an entirely different patient population. Right? What has been the patient prescribed, or what are they being told to do, or what's the intervention that we want to do? Comparison. What's the comparison? And again, usually for us, it's the standard of care. And then what are the outcomes? All right. So here was a question that we asked in the ICU. Increased pressure ulcer risk in the OR during long cases. So that was our problem. So what's our P? Who's our patient population? OR patients, but not just OR patients.
With long cases.
With long cases. OR cases with long cases. So we had to define what we call the long cases. And in this case, we said 4 hours. Now, our intervention that we were interested in was, they have those gel pads, you know, that they put down. It's the same things you actually have on your bike seat. Or an egg crate, because we love to have egg crates. All right? You still see them wander around the hospital. All right? And our comparison was the standard OR mattress. And it's actually a pressure reducing mattress already, but then we put an overlay on top of it. And our outcome, we would really like to know about pressure ulcers, but it's pretty hard since they're a fairly rare phenomenon. We took a step back and we said the intent of a gel pad is to reduce pressure. So let's measure pressure. Just see what the skin interface pressure, how much that is. All right? And I did this with one of our clinical nurse specialists, Cecil King. King and I did this in the OR. This was our professional practice group from the operating room. So all clinical nurses, this was their question. And we went out then, so the next thing was we said, okay, now we've got a PICO question. So we trundled off to the library to see it. And what we found was that there was absolutely no evidence to suggest what was a better pressure reducing surface in the operating room, beyond what the companies were telling us. Ruh-roh, right? Levels of evidence. So we actually did a performance improvement project, and we asked the question, in patients, all right, we wanted to know, what we really wanted to know was in patients for long cases, but we said we're just going to look at 10 subjects, and we took healthy subjects because we didn't want to expose anybody else. Selected from diverse body habits, so we wanted tall, short, under ideal body weight, above ideal body weight, short-necked, long-necked. We always have this one guy in our OR who has dreads. He's in every one of our studies. In on three different OR surfaces, so just the plain mattress, egg crate, or this gel pad, and in 2 different OR positions, so either flat or sideline. All right, and we wanted to look at peak interface pressure, so our outcome was peak interface pressure. All right, and here's what we found. Here are the results of our study. So we're actually using a pressure mat there to evaluate that. Now, the brighter the color, the higher the pressure. The top is the gel pad, the bottom is the egg crate. What's the answer to the question? Egg crate. Does it surprise you? The gel pad is advertised as a pressure reducing surface. This is at 150 seconds after. It's not going to get any better, right? It'll only get worse. You know, the sales reps will say, well, after a few minutes of lying on your hip, it'll actually, it's like, okay, where's that weight going? You know, laws of physics say if you weigh 150 pounds at the start of the surgery, minus whatever they take out of your body, you're going to weigh 150 pounds when you come out. You have 200 pounds of pressure on your hip right now. It's not going to move unless somebody repositions you. I'd explain that to the sales rep. So that was kind of an interesting, so we said that gel pad, you know, it's just giving us a false sense of comfort. We think we're doing something for the patient. Very, very clearly we're not. And then we were using this gel roll underneath their arm, and immediately put their arm to sleep because it was compressing their neurovascular. And one of the OR nurses said, oh my God, my arm just went to sleep. And I said, well, your patient couldn't tell you that because they're already sedated, right? So isn't that a problem? So they actually had to go back and figure out how they were padding the arm. This gel pad was too big. So now, so then if I told you we're not going to use gel pads anymore, we're going to use egg crates, what's your next question? Does that answer it? So we should get rid of the gel pads and we should start using egg crates in the OR again?
The issue is the egg crates, they're a foamy material, they're not really easily cleaned.
Okay, well they'd be one-time, they'd be one-offs.
Yeah.
What else? You know, it's wrong, you don't use egg crates between patients, right? So, but there's a cost in our landfills. Where are we green here in Seattle, right? But what's the more, this were measurements taken at 150 seconds. What's the issue?
Did you go further out than?
Is it maybe time, like how long they were?
How many of you have seen an egg crate that somebody's been lying on for a little while? What happens to it? It's compressed, doesn't it? So what we know is that the gel pad wasn't it. The egg crate, short term, appears to be better, but we still haven't answered the 4-hour question. And we're still in search of there is. We published as we were the first people to publish. We published and people are like, you guys need to replicate that, find something better. The gel pad guys weren't able to, but so it answered right away that. So we didn't come up with a perfect solution, but we have other ideas. Because then we had to figure out where our patients were getting pressure ulcers on the long cases, and it wasn't on their sacrum. What do you think it was?
Their
head.
sides, shoulders, head,
Back of their head. And this was in our high-risk cardiovascular patients. So those patients are in the operating rooms as much 12 hours, and they are hemodynamically compromised. They may have been in the EP lab before that. They were probably sick in the emergency department, so they have been on their back for an extended period of time. And we saw an uptick in occipital pressure ulcers. Now, the nurses where they were being discovered was out on the med-surg floor. And so if you looked at the numbers on the med-surg floor, you're like, gosh, you have a whole lot of pressure ulcers out on your med-surg floor. And they're like, what? What? They came to us like that. It was the ICU, right? So they're pointing their fingers at the ICU, and the ICU is like, no, it wasn't us. It was the OR. Right? And the OR was like, no. You know, they were fine when they got here. They probably had it from being in the EP lab. So we were doing this whole. So we brought it together and we said, our patients are too sick. It's a continuum of care. Everybody has to be all in. So when you're talking about evidence-based practice, you may be fixing something in just your little area, but you have to think about the patient's continuum of care. You know, so the ICU nurses wanted to fix something that was happening in the OR. We're like, okay, how's that going to go over? So if the ICU nurses come out to your floor and tell you they're going to fix a problem for you, not well received. So you want to, you know, come up with a PICO question that's in your backyard. You don't want to try and fix the pharmacists or the surgeons, all right? Fix something that you own. But we then did a similar study in the OR, again, same group in the OR, and we looked at pressure under various devices that they put under patients' heads in the operating room. And the design of those is really keep the head slightly hyperextended, right? Which if you think about it, it's all that pressure on their head and keeps it aligned for airway management. We went out and bought every product known to man. So because they were all like, well, we'll give them to you. We're like, no, we're just going to provide them. And we tested them. So take a look at mat number 2 there. Look at that. It's harder than the floor. And that's at 150 seconds. That's at 100. Imagine a patient on that for 4 hours. And that sucker is being sold as a pressure reducing surface. That's a problem. have known that if we hadn't gone out and evaluated that. So our PICO question was then, in our patients, in patients undergoing long cases, what is the best, what is the optimal pressure reducing surface for the occiput? And so the one up here on the first one there, and actually the one down here in the bottom, sort of just a little yellow crescent, that's actually foam, the blue foam donut. And what we found was that those were probably the two best surfaces. But then we had to ask that next question, or what happens after 4 hours?
What was the first one?
It's gel.
Gel.
It's a gel pen.
Oh.
It's gel. So we said, but what happens after 4 hours? And what we found was that the foam donor at 4 hours actually compresses. And we did this in my office because I didn't want anybody to have to lie in it for 4 hours. We had to find a surrogate for the human head. Do you know how much the human head weighs? If you've seen Jerry Maguire, you know. 8 to 10 pounds, right. So I actually have 8, 9, and 10 pound medicine balls in my office. We figured out which one had the closest profile, and we just monitored them for up to 12 hours. So every 15 minutes I sat there for 12 hours. Things we do for science. But what we came up with was that foam donor actually works for up to 4 hours. So for short cases, it was perfectly fine. But if you're going to have a high-risk patient for a longer case, then you had to have a gel. So then, these were the clinical nurses. They said, okay, we've got to take this now to the OR, or to the anesthesiologist. And they went and the anesthesiologist said, we don't have a problem. There's no problem. Those patients don't have occipital decubes. And you want to say, okay, number one, did you really look at the back of their head when they came off the table? You know, when they come off, nobody rolls them, other than maybe get the sheets out. Everybody just, they get moved. And we said, yeah, we do have a problem. Here's the data. Here's our solution.
Well, then there's also the thing that I might not present right away.
Right. But if you actually look, you probably could see it, but you really have to look to see it. And that's why the med surg nurses were getting nailed with it, all right? And so we showed them that, and we showed them the data, we showed them the solution, and we said, just will you confirm that this is not going to interfere with your ability to manage the patient's airway, right? You have to remember that as well. Our anesthesiologists now won't start the long cases. They went out and bought these. They're like $150 a piece. They're reusable. So the effects on the landfill are great. The anesthesiologists are all in. So again, it's not just nursing, but it was a PICO question that started that in that particular patient population. How do you do that? And then we also did it in the ICU and looked at a different strategy in the ICU. And this then is that critical piece. You have to say, how do we know we've made a difference? And the outcome is pressure ulcers. So when we started this, we had 8 in a year, which is a lot. Think about somebody with a pressure ulcer in the back of their head, the morbidity associated with it. Since 2013, we've not had any. So if we put that process together. And we also put together not only just these technical solutions, but we put together a communication pattern between the ICU and the OR to identify high-risk patients and make sure that everybody's got their eye on the ball the whole time. All right. Okay. So I want to just quickly go through searching for evidence, and then I want to look at a paper, because I know I'm starting to run out of time. I always do this.
That's okay. Yeah, we have till 9:30.
Oh, okay. Well, before your bladders. Okay. So questions about the PICO question. We'll go through that one more time. How many of you have heard about that in your undergraduate programs? Like a little bit?
Well, you haven't heard the acronym PICO, but I've heard it's the same basic principle.
Yeah. So it's again, it's really refining your question. So instead of starting with the ICU nurses, when I first came to UW-MC years ago, said, "What's the best way to measure temperature?" And I said, "Into for what purpose?" Right. So we did that. All right. Now the next thing is that once you have that PICO question, all right, and the importance of that is that that comes from the bedside. It's not you're out there necessarily searching the literature and going, "Oh, we need change." It's an issue that comes from the bedside. That's the most important thing. We're looking at something that affects direct patient care, and you go through that. Who are our patients? What are their problems? Oh, we need to be doing that better. That then drives you into the literature. All right. So, how many of you have had a class on how to do a library search? Because all you should all be very facile at this, right? So let me show you sort of some practical tips again on how to quickly move through this, and then a little bit about how to look at the literature a little differently than perhaps what we taught you in nursing school. All right, just a little bit. All right. So this is an example. Focus on fall prevention in hospitals. One technology is the bed alarms, and so the question becomes: is how effective are bed alarms at preventing falls? Now, if you were going to refine that question, how would you refine that question and put it into a PICO format?
Choose a population to say.
population, okay, so you might wanna think about that. Alright, what else?
What type of bed alarms?
Okay, what type of bed alarm, so my intervention, what
Mhm.
kind of a bed alarm, okay? What's the C?
Different persons, so.
So compared to a current bed alarm, we're looking for a better one or no bed alarm, right? And then what's the outcome?
Less falls.
Less falls.
Right.
Yeah, okay, so less falls. And probably less falls associated with the patient getting out of bed unattended versus patients falling in the bathroom. They just did a video clip I just saw yesterday at UWMC, and they had, like, about safety, and they had this poor guy, he'd been a nurse there at UWMC for a week, and they were like, and the message was safety before modesty. So if you have a patient in the bathroom, you actually have to stay with them in the bathroom, which is not our norm. Just societally, that's not our